One of the biggest risk factors for Alzheimer's disease is hearing impairment.
Really?
There are so many primary insomnias that are associated with neurodegenerative brain disease. If we don't diagnose them, I do think that's going to accelerate the decline for the brain cell.
Dr. David Carr, MD, who is a renowned professor of medicine and neurology with over 30 years of experience and reputation as a trusted voice in the medical community.
What type of effect do you think that these medications are going to have in the long term on diseases like Alzheimer's and dementia?
What is this white matter? What are the correlates? Is there anything we can do to treat or look at it?
When a patient is acting out, don't get furious, get curious.
That if your lifetime risk, say in your mid-50s, of getting Alzheimer's disease is, say, 10%, you have a 10% chance, and you have a primary family member with the disease, your risk is going to go up threefold, about 30%.
Okay, we are so excited to have with us this morning Dr. David Carr, MD, who is a renowned professor of medicine and neurology with over 30 years of experience and reputation as a trusted voice in the medical community. He has made significant contributions to clinical practice and medical education, advocating for patient-centered care and innovative healthcare solutions. In today's episode, we are going to discuss dementia and Alzheimer's and explore the latest advancements through Dr. Carr's extensive knowledge. Dr. Carr, welcome to the Invigor Medical Podcast. We're so thrilled to have you.
Natalie, Derek, so glad to be here.
Good. And a fellow Midwesterner, I mean, we are currently in Southeast Washington, but me originally spent the first 30 years of my life in Southern Indiana, and you're currently in St. Louis. Is that correct?
That is correct. St. Louis, Missouri. Yep.
I love it. That's not about 2.5 hours from where I grew up. All right. So tell us a little bit about yourself. We want to cover. There's so much here, and I know that Alzheimer's and dementia. There's a lot of questions surrounding that, and so much research still coming out on what causes it and how we can treat it. So we want to get into the meat potatoes here, but we'd love to know a little bit more about you and your background and what got you to this place where you began so earnestly researching and treating these conditions.
Well, you bet. I was very early on through high school and college. I had an interest in long-term care and also dementia and patient care. And a lot of that had to stem with, I started off as a CNA, or we used to call them orderlies back in the day. In the nursing
that's
home.
Right.
And the nurses saying, we really need people to come into this field of geriatrics. There's very few people that do that. And I have to say, 30 years later, that's still the case. We need to attract more people to the field. But it just felt comfortable. It felt right. And I ended up getting a position 3 decades ago at Washington University. And they have had historically an extremely strong devotion to geriatrics and especially dementia research and clinical care. A lot of that came from Dr. Leonard Berg and John Morris, a couple of my mentors, and that's followed with Dr. Holtzman and Bateman. So there's just been a sort of a who's list of individuals that have advanced dementia care, research, and clinical care. I got in, I would kind of consider in the groundwork, and every few years it's even more fun. And I just think bringing my skill set, if you will, and my passion for older adults and communication and ability to work with the neurologist as a geriatrician. I kind of bring a unique skill set to them regarding comorbidities, polypharmacy, issues related to cognition. So it's been a fun ride.
Yeah, it sounds like it. There's a lot to unpack there. But as we were prepping for this episode and I was thinking the direction I was going, I was kind of imagining who the listeners might be that are tuning into this episode, right? You might have your camp that's just like lifelong learners, loves to dig into things like this and have better understanding. And then I think the other group is going to be people who either A, have a loved one who has been diagnosed or was diagnosed in his past with, dementia or Alzheimer's, and or because they had a loved one in their family who has lived with or unfortunately passed away with these conditions, are concerned about the possibility of getting Alzheimer's or dementia themselves, right? And so that's kind of what I was thinking about as prepping for this episode and who might be listening and what it might be that they want to learn from this episode, because we're always just trying to equip people with more knowledge so they can live a healthier, longer life. So I would personally like to start with helping our listeners understand what these diseases are. What is Alzheimer's? What is dementia? And what are the differences between the two of them? Maybe some common misconceptions that you've seen from people and understanding the differences between these two.
Great question. And I'm still asked that every week in my memory clinics. So I think it's best to start with the term dementia,
Okay.
which in sort of a lay definition or term, if you will, would be a change in cognition or social behavior or impairment in occupational ability. That's a change from baseline. So in other words, you have cognitive change, we can test for it, and it's impairing your activities of daily living. So that's just a general syndrome, though. Dementia is a group of different diseases. I think people can appreciate that dementia could be maybe from a B12 deficiency or from medication. So I do think Alzheimer's disease is one cause of dementia. Now, it turns out to be one of the most common causes of dementia. And it's a specific brain disease that affects the neurons that eventually get inflamed, injured, and we lose them over time. And it can present in a lot of different ways. We always thought historically it was related to short-term memory, but we know now that it can present primarily as language, frontal lobe impairment, which can be personality changes, impaired attention, the back part of the brain, visual spatial recognition. So Alzheimer's, the specific disease, dementia is a syndrome or group of diseases of which Alzheimer's is one of them.
Okay, and so if I'm hearing you right, it sounds like dementia can be a precursor to Alzheimer's, but is not always. Sometimes dementia can be something separate that doesn't lead into Alzheimer's. Am I hearing you right?
Well, close. So I wouldn't call dementia a precursor of Alzheimer's disease.
Okay.
I think we appreciate Alzheimer's disease. It changes now with all the different research centers across the globe where we followed healthy, cognitively older adults over time, that there's this preclinical stage where the plaques and tangles, which are part of the pathology of Alzheimer's disease, accumulate. Then you get a very early stage where you can test abnormally on your cognitive tests. And then you move into where it's symptomatic and people recognize it. And in those early stages, we may call that mild cognitive impairment.
Okay.
And that is a precursor, if you will, to progressing to impairments in activities of daily living or a dementia. Now, not all mild cognitive impairment, basically somebody who has a change in one of their cognitive domains, we can test for it, but yet doesn't have impairment. Not all of those will progress, but we know Alzheimer's eventually will. So dementia is a little further along the spectrum. If you look at normal aging, mild cognitive impairment, and dementia, I think it's important to know Alzheimer's can kind of go through all those different stages.
Okay.
I think that's super interesting. You know, as you're talking about this, I think about something that happens very commonly, I think, within society is that, like, anytime someone shows any sign of memory related, maybe even it's me, like if I had a short lapse of memory, I'll say, oh, it's the Alzheimer's kicking in, you know? And it's like, I think that people kind of throw around this term somewhat nonchalantly. But I don't know, it's like, in that regard, what would you give, or what would you tell people that are just kind of like throwing around these terms in a somewhat nonchalant manner?
I think it's important to have a provider or clinician evaluate the patient with some cognitive changes in clinic so we can weed out. Is this worried well? I see a lot of patients that come in whose memory and thinking are better than mine, but they've had a parent or grandparent with the disease. They're very concerned, but yet they test great. And so I think, you know, to determine, is this a mild cognitive impairment? Have we reached a dementia? What the etiology? That's where I think going into a clinician will help. Good start is the primary care physician, but many of them aren't equipped nor feel equipped to really make a solid diagnosis. So referral to neurologist or geriatrician or psychiatrist may be in order.
So in that regard, how can someone know for certain, or are there what diagnostics are used to determine whether someone has dementia, Alzheimer's, memory-related decline?
So great question, Derek. And I think the whole field has exploded now with what we call the Alzheimer's disease biomarker tests.
Mm.
Prior to them coming on the scene, Alzheimer's disease was a clinical diagnosis and still can be and often is, by the history, the exam, cognitive testing, brain scan, blood work. We can often make a specific diagnosis regarding the disease. But we found out there was a landmark study published a few years back called the IDEAS study. And they found out that even in a dementia subspecialty clinic, we get it wrong about 10 to 15% of the time. So in other
Wow.
words, somebody comes into us and we say, we think you got Alzheimer's disease. Further testing showed they didn't. Or we said you didn't, further testing showed they did. So certainly it's challenging to make a specific pathologic diagnosis of what's going on in the brain. We could get close clinically, but it's not as accurate as you'd like it to be, especially if you're prescribing drugs that target the pathology, like the new drug lecanemab. So we have additional tests. We have an amyloid PET scan, which is increasingly being covered by insurance that can rule in or rule out Alzheimer's disease. Across the globe, there's lots of blood work tests that are gaining steam, and I think eventually will be covered by insurance companies. And we also have some of the traditional spinal tap tests, which are very good and often covered by insurance to rule on or rule out Alzheimer's disease. But obviously, that's another step many patients are a little hesitant to take.
Yeah.
Yeah. Okay. So when it comes to testing, how early when doing these tests can you detect Alzheimer's? And is there a benefit to being tested at a younger age to see if you have this marker and are going to develop, Alzheimer's or dementia and, for ways to sort of head it off at the pass and keep it from happening? I mean, is that a thing?
Yes, so it is a thing. Clinically, it hasn't arrived yet because we haven't figured out giving drugs to people that have the pathologic changes of Alzheimer's disease but are asymptomatic. Will they really help delay the onset and development of Alzheimer's disease? Those trials are ongoing.
Okay.
And it's going to be interesting because, as you can imagine, as the pathology progresses in Alzheimer's disease, the brain has more and more damage. And by the time you're symptomatic, you have a lot of amyloid in your brain and you're starting to accumulate this other abnormal protein called tau. So jumping in when you have symptoms, it's going to be hard to reverse some of the damage that's already been done. I think what we've seen so far, we may be able to slow it down a little bit, but trying to stop it or improve it may take much more backing up to an earlier stage. So we can diagnose the pathologic changes before people have symptoms and be pretty confident they're developing Alzheimer's pathology. But clinically, we're not recommending yet that you do those tests until we have some definite drugs that have shown from a cost-effective and safety standpoint, you can put off the disease.
So from this point, we're kind of talking a little bit about preventative measures. Based off all of the literature that I've kind of consumed, it seems like lifestyle factors is actually one of the best places where we can hedge our bet, right? Between diet, exercise, sleep, really between those three things, there's a lot of really very powerful mechanisms that can go into this. I'm actually when we were preparing for this podcast, when you were talking about amyloid plaques and tau protein, it actually made me think about one of the first interviews Natalie and I did with Dr. Richard Johnson, which I don't know if you're familiar with him or his work.
Yes.
He talked a lot about how fructose can really enhance the accumulation of amyloid plaques and tau proteins in the brain, and that by being cognizant and removing those from the diet can potentially help with later on in life. I don't know, maybe you can touch further into that.
Well, I think there are a lot of touted mechanisms for the pathology, not just the plaques and tangles, but how they get there and how they are accelerated. Fructose is an interesting association. The nicotinamide adenine dinucleotide, or the NAD mechanism. Some people feel diabetes or Alzheimer's is type 3 diabetes, where you've got some
interesting.
lack of insulin sensitivity, you've lost some insulin receptors on the brain cell. Vascular disease, we know a lot of vascular risk factors. But I think when it comes to some of the healthy lifestyle behaviors, regardless of the touted mechanism, many of them appeared to be a winner. You mentioned exercise. Now, we don't know the exact dose effect or the type of exercise, but in general, 150 minutes or more a week appears to be attainable for many older adults. And it doesn't have to be anything fancier than brisk walking, gardening, pickleball, if you don't fall and break any bones. We know that's really a popular one. But exercise appears to be a winner. And I think not only for prevention, but hopefully slowing the trajectory of the disease. You mentioned sleep. Too much sleep. There are people who get, 10 hours, 11, 12, or only 4, 5, or 6. That sweet spot seems to be 7 or 8 hours. And if you're not getting that and you're hypersomnolent during the day, referral to a sleep clinic to determine if you have a primary insomnia would be important, because as we cycle through the different sleep stages, if you're not getting that deep, heavy sleep, that's where the brain tends to process out the bad proteins, if you will, the amyloid. So restoring that sleep architecture could go a long way.
So I had a specific question about deep sleep, because deep sleep is associated very closely with growth hormone increases, right? Like that's when growth hormone kind of really peaks. If someone is wanting to enhance their deep sleep and is doing things to specifically like cold water therapy or sauna therapy or other things that have been shown to increase growth hormone production, do those enhance deep sleep, and in turn could they benefit removing of these amyloid plaques in the brain and helping with Alzheimer's in the long run?
So it's a really interesting theory, and there's been a lot written about it in the literature. However, I think for most of the people that are right at the cusp of Alzheimer's disease or symptomatic, those interventions potentially could be helpful sort of very early on in the stage. What happens when patients come into clinic and are symptomatic, more often than not, they actually have primary sleep disorders like obstructive sleep apnea, central sleep apnea, what we call a REM behavior sleep disorder, circadian rhythm disturbances. And I think it'd be unlikely for those interventions that impact growth hormone that really have a major impact. We have treatments for all those different conditions. So, perhaps early on in the preclinical stages, but I think there are so many primary insomnias that are associated with neurodegenerative brain disease. If we don't diagnose them, I do think that's going to accelerate the decline for the brain cell, and also increase the trajectory of impaired cognition over time.
Okay, so when we're talking now, since we're kind of already in like what could you do ahead of time, like I've heard a couple of different things, and I'm not going to be able to speak to them in high detail, but I'm guessing if I bring them up, you have probably heard them or done some research on them. One of them being B12, and one of them being medium chain triglycerides. And, taking these things and improving your brain health and possibly even treatments for Alzheimer's and dementia. So what can you say about those two things?
Yeah, so, a couple of things. First off, B12 is a very important vitamin for brain function, brain development, the genetic or DNA synthesis, repair. So when you don't have enough B12 in your system, the brain cells and your brain, your neurons in general, whether it's the peripheral or central part of the nervous system, aren't going to do well. So that is one of the blood tests that we often think is mandatory to check for people that have memory problems. And also might want to be considered for people that are on the proton pump inhibitors. They're pretty ubiquitous these days. A lot of people have reflux and they take their, Prevacid or other types of medicines. And when you decrease the acid production in the stomach, you also decrease your ability to absorb B12.
Yes.
Vegans, vegetarians, when you look at the food products, like fish, meat, poultry, eggs, dairy products, not everybody has those in their system. Thankfully, B12 is a pretty easy test. You could check. If you're below 200, you definitely need replacement, and you may even need it in the 200 to 400 range. And the good news is, if you do replace it, you can prevent either some of the neurological disease, and it also is very important for red blood cell production. You can get anemia. So it is, I think, a very important factor. So, the medium chain triglycerides have also gained a lot of steam. We know that, fish, and, fish oil and coconut oil and many of the healthy oils, if you will, are not only good for the heart, good for the brain. In fact, one of our classic nutritional prescription foods, if you will, was called Axona. Caprylic triglyceride was the name of it. And it had a little bit of a day in the sun, if you will, over a decade, maybe 15 years ago, because they did a small trial, maybe 150, 200 people, placebo and treatment group, that had pretty much the same outcomes for cognitive stability in Alzheimer's patients that some of our medicines, donepezil and cholinesterase inhibitors did. And the theory goes that our brain is relatively starved for glucose, that we just don't have the insulin receptors, and we're having trouble getting glucose into the brain cell. And if there's one food our brain cells loves, it's glucose, right? I mean, I forget what the percentage of the consumption is of the brain, but it takes a lot of energy to run our neurons. But if you don't have enough glucose, the second most popular food for brain cells are ketones. And that's what happens with medium triglycerides, is they get metabolized into ketones. Not high levels like for a diabetic that's going into diabetic ketoacidosis, about 1/1000th of that level in the blood. But it is an intriguing area, I think, like the supplement area, that unless you had a true deficiency of B12, just taking it is probably not going to do a whole lot of good. And I also think it is a big step, just to take coconut oil or take extra fish oil. I'm not aware of any large studies that have shown efficacy. I do believe, though, in a regular, healthy Mediterranean diet where you're getting oily fish in a serving or two a week over time, and olive oil, has gained a lot of recent press. I think those are great strategies to have day in, day out, year in, year out for your diet.
That makes sense to me. Quick question though on B12, because from what I understand, not all B12 is created equal. I know my mom was always telling me, make sure you get the methylcobalamin. Is that right? Yeah. So
I think that's a very good preparation from that standpoint. And most people can get by on taking the pill. But if you're going to take it 1,000 micrograms a day, it's probably a good dose. Sometimes I see people on 100. It may not be enough because only about 1% of it is absorbed through the stomach. Now, if you get a very low B12 level to the point that, you've got, some peripheral neuropathy and unstable gait, or you've got an anemia, you may benefit by the shots, because the shots will replenish it quicker and in a safer fashion than waiting for the supplement.
Hey, I hope you're enjoying today's podcast. I just wanted to take a quick break because if you're listening, you probably know what we do here at Invigor Medical Podcast, but maybe not what we do at invigormedical.com. So let me introduce us. At Invigor, we provide prescription strength treatments and peptides for weight loss, sexual health, and lifestyle optimization. Every treatment plan is carefully prescribed by licensed doctors and sourced from legitimate pharmacies. You don't ever need to buy questionable research chemicals again. And bonus, as a podcast listener, you get a 10% discount on your first treatment plan with code podcast10 at invigormedical.com. Now, let's get back to today's episode.
I gotcha. I take mine sublingually, melt it under my tongue as well. there's some great brands out there, but just another thought. My mom's always like, why are you taking your B12 and what kind are you taking? She's great about that stuff. She's always like big on, nutritional healing and vitamins and everything. And so, I'm really grateful for that. Okay. So, I was going to go somewhere else, and now I started talking about B12 and I got a little distracted.
I was going to ask, so we're still in the realm of prevention, and I imagine that we're probably going to move from prevention to the realm of like when you actually have it, what are the best kind of treatments, and both for people that are caring for people with dementia and Alzheimer's, and then also those that are, kind of in that pre-stage where they're afraid that they may go into it. But while we're in the prevention stage, you briefly touched on nicotinamide adenine dinucleotide.
Good God.
Or NAD+.
Right.
Can you dive a little bit more into what kind of role NAD supplementation could potentially have in helping prevent Alzheimer's?
Yes, there's a lot of work. This is an enzyme that seems to have a critical role in cell function, the metabolic pathways, the DNA repair, how the genes remodel, if you will, the aging mechanisms, immune system. So it is an important pathway for production of energy. So within the cell, we have what we call our batteries or energy powerhouses, the mitochondria. And they function on this ATP, which is, if you will, their fuel and energy. Cell machinery would just slow down if we didn't have it. And NAD plus is critical for that. There's been a spate of basic science, rats, mice articles that show that supplementation, and there's several different types of ways to supplement with the precursors of NAD plus. And one of them, being nicotinic acid or vitamin B3. In fact, there's an old disease called pellagra that was described back years ago, the 3D, where you get diarrhea, dermatitis, and dementia. And
that sounds terrible.
Basically, and it was. And
yeah.
So replacement with nicotinic acid was cure in that sort of disease, which is rare. But I think the human studies have shown some benefit, exercise tolerance, helping out insulin sensitivity, showing some anti-inflammatory effects, but early yet to say you need to go on a supplement. I think those trials should and need to be done in larger studies, but it is growing. But, while we're talking about risk factor prevention, in addition to the sleep and exercise and the diet, one of the biggest risk factors for Alzheimer's disease is hearing impairment.
Really?
And it's actually in a recent review in Lancet a few years ago, it had a higher risk than any of the other risk factors. Now, we don't know the mechanism. I mean, I could get into some of the specifics, but it also appears that if you have hearing impairment and you do get amplification or hearing aids, that may decrease your prospective risk of getting the disease. So hearing, I think, is important. Education, community engagement, treating your blood pressure, diabetes, hyperlipidemia, reducing obesity, limiting your alcohol intake, preventing head trauma. I think those are keys, kind of the top 10 list. But atrial fibrillation, a growing risk factor for dementia, so treating that's going to be important. So there's some medicines, we may get to that in the polypharmacy piece, that appear to put you at risk. I do think, we've probably only discovered of the modifiable risk factors, we probably, if 100% you were able to capture risk for Alzheimer's disease, we probably only have 50% or half of them right now. So there's a lot of room there for science to help us out.
It kind of sounds like, cancer is kind of in the same kind of realm where it's like there's so many things that can feed into it and that could potentially make things worse. One thing that you touched on that you kind of brushed over and I want to dive a little bit deeper into is the effect of obesity on Alzheimer's. And we've talked a little bit about the metabolic effect and that kind of a thing. So I want to dive into that and then also kind of couch in that question. There are new treatments out that are now very, very effective and are very popular. Semaglutide, Wegovy, Ozempic, those types of things. What type of effect do you think that these medications are going to have in the long term on diseases like Alzheimer's and dementia?
We very well may see a reduction in Alzheimer's disease because of treatment. What's interesting is there's no doubt the absolute number of Alzheimer's cases is continuing. We got about 7 million people in the United States right now, probably 13 million by 2050.
Whoa.
But if you look at the actual number of new cases per population, they've been going down. And the question is why? And I think because people have been getting their blood pressure treated, they've been getting their blood sugar treated, they've been on statins for their cholesterol. And I think these midlife risk factors for Alzheimer's disease, as a society, we're doing better addressing them. Now, we still have pockets in the community, Blacks, Hispanics at higher risk for Alzheimer's disease. Some of that's genetic, but some of it's, environmental, higher risks of diabetes and hypertension, and making sure they're treated adequately for those conditions. But I think it's a huge area, and these GLP-1s and these diabetic medicines, I think you're going to eventually see trials for prevention for Alzheimer's disease, or even after people have symptoms. But obesity is a funny thing because it's a risk factor in midlife. But what's very interesting, after age 70, obesity kind of drops out as a risk factor for heart and disease and Alzheimer's disease. There's this sort of paradox. It's a little controversial, but definitely if you're obese throughout your lifespan, say 30 through 70, that does appear to be a risk factor. And I do think additional treatment with these medicines could very well decrease the future incidence of Alzheimer's disease.
My grandmother, her mother, was diagnosed with dementia, and my mother and all her siblings taking care of her, and she lived with my aunt in her last couple of years, and she has since done so much research on Alzheimer's and dementia and the markers for it, and doing her own kind of testing and some genetic testing to determine what kind of risk factor she's at and potentially her siblings, and also was trying to just figure out how to best care for my grandmother at the time, who passed back in 2016. So I said, Mom, we've got this, Dr. Carr coming on, and this is what he does and what he specializes in. Like, do you have any questions? And my mother sent, I don't know if you can see on the screen, this whole long text with questions, and it's kind of rambling. So I've been like, okay, what do I want to pick from here, Mom? But one thing she mentions, she says any links to LPA lipoprotein. Because that's something that she's done some research on. So what do you know about that, and what kind of...
There are links to LPA. There are links to LDL, not having enough of the medium chain triglycerides. A lot of these things are also associated with heart. And I often say what's bad for the heart is also bad for the brain. The good news is for most of these abnormalities in, if you will, metabolic pathways that contribute to obesity and heart disease and vascular disease, is the healthy lifestyle behaviors can really manage those. And, with the exercise and sleep, social cognition, interactions, community engagement, you can make some pretty big impacts. Now, whether or not that will become the target of future treatment, a lot of my patients are asking to have those measures checked and et cetera, and I'm deferring to the cardiologists on that one. But I do think that a lot of these pathways are going to be an option for treatment, whether it's going to be a cocktail and you'll have to address it in a lot of different areas, time will tell. But I can tell your mom's really in tune here. She's looking at all the different mechanisms from that standpoint.
Oh my gosh. She mentions one of your favorites, Dr. Peter Attia, says LPA is the #1 health concern in his opinion, and reduction of sugars in the diet. She also mentions Eli Lilly doing a huge cutting edge Alzheimer's drug trial right now. And she also wants to know, she was talking about small vessel disease in the brain, and that being a cause of dementia and possibly how to treat it. So that's I'm not going to go line by line here, but I feel like those are the high points. Sorry, Mom, that's the best I can do today.
No, you're doing, Mom's doing great, and she's spot on, and she's just soaking all these different things in.
Yeah.
I'm not sure I can remember all those, but I'll start backwards because that was the last one that I heard. Talk
Yes.
about memory issues.
Yeah.
So small vessel disease is not always present, but in most of the MRIs we get of people over 70, we will see these white matter hypertensities that show up on MRI. And if you kind of picture a brain, you've got the gray matter, that's sort of the cortex where we have a lot of our complex thinking. And then the tracks come in to form the white matter. And that shows up a certain way on MRI. But when you get white matter hyperintensities, you get these areas of the brain that are damaged, not always from atherosclerosis. Most of the time it's from vascular disease, but people can have inflammation from rheumatologic diseases, vasculitis, etc. But most of the time in Western society, in people that are of advanced age or have high blood pressure, high cholesterol, blood sugar issues, it's atherosclerosis. So there are pretty strong associations with white matter disease and Alzheimer's disease and what we call vascular cognitive impairment or vascular dementia. But we're also finding out not all white matter disease is the same. So the fluid-filled areas of the brain, if you look at what we kind of call the frontal horns, the front part of the brain, the white matter that surrounds that is very much associated with hypertension, hyperlipidemia, et cetera. And we know there are functional signatures. People will have slower reaction time. They may have gait and balance problems, urinary overactive bladder, incontinence, maybe issues related to short-term memory. But there's white matter that occurs or small vessel disease in other areas of the brain. And this could be from the proteins that coat the blood vessels. We call it cerebral amyloid angiopathy, if you will, amyloid plaques that are sitting in the capillaries. And that can show up in different areas on the brain too. So, and those have their own sort of clinical correlates, pathologic and or cognitive. So we have a lot to learn. Your mom picked out a very hot area that a lot of people are studying.
She has a gift for that.
what is this white matter? What are the correlates? Is there anything we can do to treat or look at it? I think that's the case. So Eli Lilly and other companies, now that lecanemab and previously aducanumab, these monoclonal antibodies that target the protein pathologies, it's become a hot topic of area. And Eli Lilly, and there are at least another 10, 12 companies that have these monoclonal antibodies in different, phase 1, phase 2, and phase 3 trials. Donanemab is another one that FDA is looking at right now. I think to me, the most exciting part of this area is we now have tau monoclonal antibodies that are being tested. Now, it took us a long time, over a decade, to figure out on how to target amyloid, how to get rid of it, and how to do it kind of safely, pretty safely. So we're going to have to go through, I think, the same thing with the tau antibody area. I mean, the trials are there, we're looking at them, and it may be eventually you're going to need a combination of both an antibody against amyloid and also one against tau to really stop the disease and or improve it. And, you got to look at the timing. But she's right. We were pretty close to being on life support for the drug industry and Alzheimer's disease. It had been so long since we had a drug approved, so many failed trials. And thankfully, there's still a lot of effort being made in this area. And there's other targets too, as we've talked about, besides just the monoclonal antibodies, which are expensive to make, expensive to administer. But Alzheimer's is a pretty expensive disease. I think we're around $350 billion this year in direct and indirect care, and that's going to be up to $1 trillion of healthcare costs by 2050.
Yeah. I'm curious, as you're talking about these treatments, and if you want to go a little bit more into the kinds of treatments that are out there and what they are and how they work, because I think that's a kind of good area for us to explore next, is, are these what we're exploring, what's available right now, or what we're researching and trying to get out there, primarily about treating it as in like reducing symptoms, or are we putting a lot of effort into reversing or like heading it off at the pass to figure out what is actually causing this? Because I know sometimes treating a symptom of a disease is not the same thing as treating a cause of the disease. So it's kind of a weird way to phrase the question. I guess I'm wondering if the efforts in researching how we can treat symptoms versus disease, are they on the same like street right now, or are they like kind of separated and we think what's causing it is different than what the symptoms are that we can treat? Is this making sense?
It is, Natalie,
Okay.
and it's a great question. But let me back up just a little bit before we jump into the current medication treatments. We often talk about, pharmacological and what's available, but I don't want the caregiver to be lost here, and he or she may not. But, education, getting information, whether it's from the Alzheimer's Association in St. Louis, we have another great organization, Memory Care Home Solutions. And I think audience needs to know that part of this treatment is informing people, what are the different types of cognitive domains that have been affected, where are the impairments from an activities of daily living standpoint, what are the resources in the community. So I think that's an important part of treatment. But going into your question, we have probably two types of drugs, those that kind of treat the symptoms, if you will, and then those that are disease modifying drugs that are getting at the pathology. So the classic medicines for Alzheimer's disease, we call the cholinesterase inhibitors, which is nothing fancier than an enzyme that blocks one of the neurotransmitters or little communicators between the brain cells, acetylcholine, and it helps boost those levels. Donepezil, or Aricept, galantamine, Razidine, rivastigmine, or the Exelon patch are examples of those drugs. They can help with some relative cognitive stability, 6 months, maybe a year. And they are kind of our first line agents for people that have cognitive impairment that affects their activities of daily living. I don't typically prescribe those in people with mild cognitive impairment because the data shows that it's not getting at the pathology of the brain disease. Yeah. So it's a little counterintuitive. People come in my clinic and they're like, all right, you're saying I have mild cognitive impairment. You're thinking it's Alzheimer's, and you're not going to give me an Alzheimer's drug. And I'm like, no, you're too good for it. And if it progresses to the point you have impairment in your activities of daily living, at that point, we typically prescribe it. Not every dementia expert operates that way, but I think that's evidence-based. The other class of drug we prescribe for the symptoms are what we call NMDA antagonists, and those help. We're not quite sure how they work, but we think they protect the brain cell from calcium influx and kind of prevent cell death, if you will. Memantine or Namenda is the one FDA drug approved for that. Now, Memantine isn't approved for early stage disease. It's more moderate to severe, but we prescribe that a lot, and a lot of times we'll add it to one of the conventional agents like Aricept or Exelon and have dual therapy. These drugs can sometimes help with the behavioral symptoms of Alzheimer's and with some relative cognitive stability, but eventually people progress. Now, the only drug right now that's available, at least in the U.S., is lecanemab, which was approved about a year ago during this month of May. And that is a disease-modifying drug, which slows the progression of the disease. Now, we can have an honest debate of does it slow it enough to warrant its cost and potential for side effects. Obviously, the FDA and Medicare thought it would, although Medicare did qualify that. And if you're going to be an infusion clinic and you're going to give lecanemab, you have to put information into a registry that will go in so Medicare can look, okay, we know the drug company achieved the results in the study in a research sample. If we're going to spend all this money with this drug and potential side effects, are we achieving the same outcomes in the real clinical world? And I think it's an extra step for the infusion clinics to have to put all your information in a registry, but I think it was a smart one for Medicare to do that.
I think so too. I think that that makes a lot of sense to me. It just seems like there's so So much still coming out and being learned about this disease. And I think that kind of gives me a little bit of hope, knowing that there's that additional step to kind of track and see what this new drug is doing and how it's actually affecting people. And maybe the answer is this drug, but I'm curious, what research right now that's coming out or being done about Alzheimer's and dementia are you really excited about?
Well, these are some of my biases because I'm involved in some of the clinical drug trials that target the monoclonal antibodies. So I think getting back to the tau antibodies, I'm really optimistic once we figure out the mechanism and we can show in the tau PET scans removal. I'm cautiously optimistic we may actually reach a point where we can stop the disease dead in its tracks. Now, whether that has to be given with monoclonal antibody treatment or not, we'll just have to see. But there are other mechanisms. So there are other pills and other types of areas that people are looking at. So I think some of these diabetic agents, as they work their way through the pipeline, again, probably more for preclinical or the earliest cusp of the disease. I'm really excited about these metabolic pathways that will help with the drugs. And, we didn't find that statins per se, once you're symptomatic, really prevented the decline of Alzheimer's disease, if you will. But backing up with a combination of a statin and a GLP-1 or what are the new diabetic agents, could this be a way to put off Alzheimer's disease for 3 or 5 years? Another mechanism that I'm fascinated about is sleep. So the sleep disruption we were talking about, what comes first, the chicken or the egg? Are people having neurodegenerative brain disease and they're not sleeping because of that? Or have they had this primary sleep disorder that's bringing it on? And does it matter if you can treat the sleep more effectively? Maybe you can stop or slow the disease down. And we have a researcher who's looking, there's a new group of agents that I think you can appreciate with melatonin. The levels come up at night and the orexin is a hormone that comes down, and then that starts coming up to wake you up during the night while your melatonin levels go down. So there's a lot of these new agents that block orexin and really help for sleep maintenance. And Suvoxaran is one of those, Balsamra. But there's research looking at how can we modulate sleep, get people a good night's sleep, a quality sleep that helps restore the brain. Maybe it's through the growth hormone levels. Maybe it's more through reducing amyloid from accumulating. But I think there's a lot of benefits. And I think another area of research is exercise. And when you look at exercise that combines cognitive ability and physical activity, ballroom dancing, square dancing, some of these, maybe racquetball sports where you're having to think cognitively and also be active. I'm waiting for a randomized trial on, again, you're going to have pretty healthy participants. You're not going to take somebody who's frail and 90 years old. But I still think, we jump to drugs, but I still think there's a lot to be done. It was like the finger trial, which I think was from Finland, where they looked at exercise and diet in an older group and found that it slowed the incidence of Alzheimer's disease. I think we can do this, and it doesn't necessarily have to be medication.
Yeah. Well, I think that a big part of that, and, you've talked about how the occurrence of these diseases is going down. I think a large part of that is because of really good educational resources that are becoming more and more prevalent. That's a big part of what we do here at Invigor Medical. So we're trying to get the good information out to people so that way they can act early and prevent these things from happening. I think that just taking time into consideration, there's another huge part of dementia and Alzheimer's that I really want to make sure that we give enough time. And I think that's caring for people with dementia and Alzheimer's. Personally, something that you and I share, I also started my career path as a caregiver at a senior living facility, and I saw firsthand the type of things that can happen with people that are struggling with these diseases, and how profoundly it affects families. I've done a lot of spent a lot of time thinking, and there's actually one book in particular that I wanted to bring up by a guy named Atul Gawande, who wrote the book Being Mortal. And I think that probably the most profound point I took away from that book is that if our lives are a story, the end of stories matter, and having autonomy and the ability to control our lives regardless of the life circumstances is incredibly important. And so in that regard, what type of advice would you give to caregivers or to someone that is, in the early stages of dementia or Alzheimer's, to say, like, this is how you can reclaim autonomy in your life, or this is how you can give the person you're caring for autonomy towards the end of their lives?
That's great. I read that book too. It's a phenomenal read. So
Yeah.
really, we can recommend it, obviously, to
100%.
The audience. Yeah. So the caregiving is, so a couple parts here is the caregivers obviously need some help and attention, but how can you yourself as a patient that is wanting a say, and as you've losing faculties in your ability to function, how can you prepare for that? I think, part of it has to do with having somebody in your corner, whether it's a spouse or an adult child. And unfortunately, some of our patients, the family situations aren't good, and it's a very lonely disease if you don't have somebody with you. But if you've got a spouse or a partner, an adult child, somebody that will listen to you, you can set up a lot of things for that control, and you can talk about shared goals when it comes to things related to ICU care and breathing machines and feeding tubes. And some of those discussions are, in more advanced disease, but we don't know what the next day or next month will bring. So being able to talk about that, where you want monies distributed, a living will, an elder law attorney, I think is good. Discussing your healthcare goals and what you see for yourself. A lot of people with early disease are still very capable, very functional, and they're going to want everything done and full court press. But as people progress through the disease, their desire will become a lot less to have some of these technologies and things done. And having those discussions up front, I can't tell you now how many times I've had family members say, I talked with my mom. She would not want this done. She wouldn't want this. She would want this. Those discussions are much more common now. 30 years ago, I don't know what mom would have said, or dad.
Yeah.
So I do think education, like the programs you're having, are very important. A lot of people have, elder law attorneys, estate planners, to make sure those things are taken care of and then revisited every few years. It gets a little complicated when you have people coming in and out of marriage with all the legal and financial obligations with that. Some of my toughest cases in clinic are when you've got the adult children and spouse from a second or third marriage, locking horns and trying to figure out what's best for the one. So I think those are important open discussions to have with family members, often hard ones that are key. I can't say enough about the Alzheimer's Association. There's also gerontological care managers in the community that specialize in caregiving, and there's adult daycare in circumstances which are good. There's respite care in the home. Some of the long-term care facilities will allow for assistance. Caregiver education's huge. Alzheimer's Association, the book, The 36-Hour Day, is kind of the Bible, if you will, of information that people can use. So I think getting things out, getting them in writing, and being very transparent is important. And a lot of times those things are buried and they come out, and it's hard to get them fixed when those discussions haven't been made.
Yeah. Two pieces of advice, or not, or actually when I was receiving training as a caregiver for being able to help patients with these diseases, two phrases that have always stuck with me. Well, not phrase. There's one phrase and then one strategy. The phrase is when a patient is acting out, don't get furious, get curious. because oftentimes them acting out is them being able to express something that they couldn't express in any other way, right? And so being able to say, okay, what's actually going on here? What's a deeper issue? The second thing is, like, if they're in a alternate reality in their heads, right? Like, for example, there was a time when a lady was like treating me like I was a bellboy at a hotel, and the advice was, instead of trying to correct their way of thinking, just really quickly put on the reality that they're seeing and try to kind of go with it, because then it makes things just so much smoother for them. And it might be a little bit weird in some cases, and obviously don't do anything that's against your values or anything like that, but really trying to make it as coherent and as smooth as possible, and not jar them out of their reality, say this isn't right, this isn't true, but really going with that. What can you speak to those two concepts?
Well, those are two great points. Let me just piggyback on both of those, Derek. So one has to do with the behavioral symptoms and trying to treat them and figuring out the reason behind them. Alzheimer's Association does a lot of work around this, and they have caregiving books to talk about, but you really need to problem solve for the behaviors. A lot of times we say it's just dementia. We have a little mnemonic, the Drano mnemonic, DRNO. D is sort of to describe what the symptom is. R is the reason behind it. And then, N is for non-ordering medicine. And finally, you get around to ordering medicine. That's your last resort.
Yeah.
And reasons behind behavior. Sometimes I've had patients that have ended up, they're agitated, they're angry. You get around to examining them. They have gout. Nobody's picked it up. You got to treat their pain. I had another patient who I was getting phone calls, behavioral problems in the nursing home. I was prescribing an antipsychotic, and they were getting worse, not better. And when I got out to examine them, I had put them in urinary retention from the drug.
Oh,
and,
wow.
and they were uncomfortable because they weren't able to empty their bladder. And those sounds like silly things, but these things happen all the time. You have to problem solve with these behaviors, I think, to really make sure things are good from that standpoint. And I think I like the be curious from that standpoint. And
Yeah.
what was your second point?
It was to, if someone's like going through an experience and it's not aligning with reality, to not try to like bolt them out of it, but really just try to, as much as possible, enter into the reality and just go with it
and be with them.
And many people will do that, and some people will call it therapeutic fibbing. There's different names for this, but I've found for most of my caregivers and most experiences is that rather than lock horns, go along with it. You can't sacrifice safety. And if it's going to put you or the person in a situation that's untenable, you may have to confront. Give you an example, my dad, who's got Alzheimer's disease, he's at a nursing home in the middle of the state. My sister's there in town, and he thinks he's back in his days refereeing. He'll get up in the morning and says he has to leave. He's got to go do a football game, do a basketball game. And the staff have all these litanies of excuses as to why he doesn't go. They don't argue with him. They go, well, you have one, but it's not today. It's tomorrow. Or it's snowing. Game's been canceled. So you have to come up with these different ways to deal with it. And you can be creative. One of my favorite stories was true. And I encourage your audience, if they have somebody with behavioral problems, please attend those Alzheimer's Association peer groups that you come together to solve problems. I had a patient who continued to drive, was having accidents. The spouse called up and, well, they didn't call up. They actually gave this discussion at a peer group meeting I attended. But I thought, had she called me, I probably would have prescribed some medicine for the behavior. But instead, she said, well, he needed to stop driving. I realized he just needed the keys. So I took his keys and I just filed down the ignition key so he could still keep his keys. He wanted to hold them, but he'd go out and start the car, and he'd come back in and say, honey, I can't start the car. She goes, I know it's broken. I'll get around to fixing it. And of course, with his short-term memory, he would forget. And eventually he stopped asking to drive, but he kept his car keys. I never would have thought of that, but
Right.
that's where
that's
I
super
think,
smart.
peer discussions can really help problem solve.
Yeah. Oh my gosh, we're coming close to an end. I just wanted to see if you would touch really quickly on, because I think this is something a name in Hollywood that's become associated with the disease Alzheimer's. Chris Hemsworth, who was tested with was showed a genetic predisposition to the disease, and how it was this wake up call, and he's been doing all this stuff for like brain health. What are your thoughts on that? On doing the testing for a genetic predisposition and what comes after that?
Right. So complicated area and also a little bit controversial. First off, people should realize that late onset Alzheimer's disease, you carry a little bit of risk with family, but it's not an absolute risk. There's a rare form of Alzheimer's disease, less than 1%, which does have what we call a familial pattern of inheritance, kind of like Huntington's disease, where if you get even just one of these alleles or chromosomes from mom or from the affected parent, you will get the disease. But that's very rare. Most of it is late onset. And what I like to tell people is that if your lifetime risk, say in your mid-50s, of getting Alzheimer's disease is, say, 10%, you have a 10% chance, and you have a primary family member with the disease, your risk is going to go up threefold, about 30%. So that may get your attention. But I can flip that around and say, you got a 70% chance of not getting the disease. So yes, you're at risk, but odds are, unfortunately, cancer, stroke, something else is going to come along. So I don't want people to be overly worried. And I think most authorities right now and experts consensus in the field would say not to check genetic tests, is that there's no test that shows an absolute amount. There is the ApoE test, which can show your susceptibility to Alzheimer's disease, but we don't have any drugs to target it. It wouldn't affect treatment. So I would not recommend that patients or family members of the patients to check. Now, there's an exception right now clinically, and that is if you're going to get lecanemab, we know this monoclonal antibody for treatment, that there's a higher risk of side effects depending on your ApoE genotype or genetic profile. So in that situation, we will do genetic testing to determine your risk for taking the disease. But other than that, I think those are best done in research settings, and that may change over time. But I think that would be my advice.
Okay. Thanks for speaking to that. I just know that's kind of been like, it was a big thing whenever it came out that he'd done that, and everyone's like, oh my God. And then they're like, should I do that? My mom has Alzheimer's. So thank you for taking a moment to speak to that. And we are definitely coming up at the end of our time. It's been, I know there's so many other things that we could cover here.
Dive into,
but before we're done with you, is there any final thoughts that you want to impart to our listeners?
No, I just think just to be very supportive. If you have an opportunity to participate in research, we still believe the better drugs are yet to come. And I just want to shout out to those volunteers we have for longitudinal projects that come in and get their tests. Those that participate in drug studies, we need you because even if you participate in a study that doesn't show success, you are paving the way for informing science and helping us fight the next generation. I do think the next generation of drugs will be just that much more powerful. So I think I would end in a plea for those that have interest and the bandwidth to participate in the science, please do.
I love that.
Dr. Carr, I just want to say thank you for joining us here on the show, but more importantly for the incredible work that you're doing and for the studies that you're participating in, because not only does it take a lot of bandwidth for the volunteers, I'm sure it takes a lot of bandwidth for you to dedicate your life to this cause. So I want to express my appreciation to you and for the work that you've done.
Well, thank you for that, Natalie and Derek. It's been a blast. We'll do it again.
It's been a pleasure.
All right. Thanks so much, Dr. Carr.
You bet.
Thanks for tuning in to the Invigor Medical Podcast.
If you enjoyed today's episode, you can support us by liking and subscribing.
Your feedback matters, so feel free to share questions or future episode ideas in the comment section.
For more information about our prescription strength treatments for weight loss, ED, and overall wellness, all from qualified doctors and reputable pharmacies, visit us at invigormedical.com. And don't forget to use code podcast10 for a 10% discount on your first treatment plan. Until next time, stay well.